Hello, everyone. I'm Patricia Kaufman, co-founder and executive director of the CLL Society. We are dedicated to bringing you the most up-to-date and credible information on COVID-19. This format was designed to put your questions directly in front of our expert panel. So, above all, stay strong, put your fears on the back burner. Let's let our natural curiosity and desire to learn how to take best care of ourselves to the forefront. We are all in this together. It's my pleasure to introduce Dr. Brian Kaufman, our moderator for today.
Well, thank you, Patty. Patty was not only the co-founder and the executive director, but also is my caregiver and partner in life for about 5 decades now. So thank you, Patty. Just a couple of housekeeping notes. Everyone, this is our second time doing this. The one that we did last week is now archived on the website, and you can gather the slides from that and listen to the audio again. And we'll be doing the same with this one. And we won't be doing one next week, but I'll let you know the details later, but we'll be doing one in 2 weeks from now. When you join this, everyone is muted, and only the people on camera will have the ability to talk and answer your questions. I think the most important thing is when you look at that bar, when you look at the platform, you're going to see at the bottom, there's a Q&A, and you just click on that. It opens up whatever question you have pops up, and all the panelists can see it, and we can put it in the queue and try to get to it. As you can imagine, there's an awful lot of questions. We may not be able to answer them all, and there's a significant duplication in questions, so we may lump the questions together. After today's event, you're going to receive a brief survey, which will help us put together the best practices for any future virtual community meetings like this and during the COVID-19 pandemic. So please give us your feedback. Let us know what we did well, what we didn't do well, and that's very important for us to be able to continue and do this best. Again, this session will be recorded and will be put up live on the website. We want to thank our sponsors who really jumped in very quickly. We didn't have this slide last week, and a number of people found out about what we did, attended it, were excited and wanted to get behind that. And we really appreciate AbbVie and AstraZeneca supporting our effort. At this time, I'm going to run through our speakers. I think people know me. Tom Henry's been a longtime friend. Not only is he been the chief pharmacist at Moffitt and Roswell, 2 large cancer centers, he is also a CLL patient himself and comes from that experience. So like me, a healthcare professional who's also a patient. And Tom will be our first speaker. Susan Leclair. Dr. Leclair is a professor emeritus and has an uncanny knack to make difficult concepts accessible. And she's going to be talking to us about testing and some of the nuances in testing for COVID-19. Dr. Mato is the director of the CLL program at the Memorial Sloan Kettering Cancer Institute in New York City. So is it the epicenter of what's happening with COVID-19, and deals with a number of immune-compromised patients, and will give us a sense of that. And Dr. Brander is the assistant professor of medicine at Duke and heads up their CLL program. So here's our agenda. We're going to have the welcome is essentially done. I've introduced everyone. There's going to be some polls, and when you see the poll, you're going to have to scroll down. Then we'll have a couple slides, a very few slides at the beginning, because 80–90% of the next hour and change is going to be a Q&A, but we are going to do some polling towards the end, and that's very important that we get your answers and input on that. So when you see these, you may have to scroll down to get to them all, but if you could answer them here, that would be very helpful, and we'll just give you about 30 seconds or so to go through them all. All righty. So we have the majority of people were here last time. So I want to be clear on this. We're not going to spend a lot of time going over what we did last time. Obviously, even if we answered a question last week, it's going to be different, the answer this week, because there's more information. But we will go over and update some of what was covered last time. So some of this will look familiar, but I assure you the majority will be completely new information for you. This gives us a sense here, question two, that the majority of people understand to some extent what the precautions are supposed to be taking. People seem to understand about the testing, though it's less strong in that area. People, are mostly neutral here, it looks like, about shortages of drugs. So Tom, you're going to address that. And this is really quite revealing, isn't it, that 86% of you agree that you're quite anxious about your health during this. And what are people wanting to do during this time? I guess the most of us want to stay at home and let my family go out and do the shopping or have the necessities delivered to the house. So we'll revisit these questions towards the end. Thanks for everybody for doing that. So let me introduce Tom Henry.
Good afternoon, everybody. So one of the things that I wanted to talk about was there's been a lot of press that there may be drug shortages that could affect our CLL patients. As of about an hour and a half ago, I did access the FDA drug shortage list, and I'm pleased to report that they currently list no change from what we reported last week, that there are currently no shortages of the most commonly used CLL drugs. As you know, China is a major supplier of not only the medications that we use in the United States, but also the raw materials. So even if the medication is made in another country, the raw material may be made in China. So there have been some interruptions in production in certain parts of China as a result of the COVID cases that they had there. However, China is a really big country, and most of the manufacturing appears to be in areas that were less hard hit. We are seeing more and more reports about different airlines, FedEx and some of the airlines doing cargo-only flights to try to make sure that we get medical supplies. There was even a flight from Russia into JFK this week, bringing supplies from there. And then some of the strategies that we recommend that patients consider to preserve their supply of their CLL drugs is to do early refills. As I mentioned, 75% of the drug has to be used before your insurance company will allow a refill. So on a 30-day supply, that's about a 23-day period that has to go by. So you could essentially fill that prescription 7 days early. Similarly, on a 90-day supply, you need about 72 days to pass. So I would set a reminder and contact your pharmacy early, and then work with your provider to possibly reduce your dose. As we've seen on ibrutinib, there are patients that are taking 420, which is the standard dose. I myself take 280. There have been some published results that say that it's effective even down to 140 if you've had the 420 for at least 30 days. So, that would be like a last-ditch effort, but I would not do this on my own. Could I have the next slide, please? When we talk about our non-CLL drugs, we mentioned that comorbidities do increase your risk of having a bad outcome from the COVID-19. And so we want to make sure that people have control of their comorbidities. When those conditions are well controlled, very often you have a similar risk to the general population. So I think a really good example is patients that have well-controlled diabetes tend to have the same outcomes as patients that don't have diabetes. Be proactive, and again, in the case of your maintenance meds, order them early. Ask your doctors for a 90-day supply if your insurance will allow it. And then consider mail order pharmacy temporarily, or a pharmacy that delivers. Pharmacists are allowed to transfer in all the states that I'm aware of. And essentially the new pharmacy just calls your original pharmacy and they initiate a transfer. And then if shortages develop, work with your medical team to find clinically appropriate alternatives. And I think the way to make sure that that works is to make sure that you do try to fill your prescriptions early, so that if you find out that there is a shortage of a drug that you've been taking for a while, it's not the day that you ran out of pills that you call and now we have to scramble to find what an alternative might be for you to take. And then we may not be able to get a hold of your provider. So, be a little proactive on that. And I will at this point turn it over to Dr. Leclair.
Thank you, Tom. I would like to continue most of the slides from last week and go over them one more time. I went over them relatively fast. And for those of you who weren't here last week, we can go over those, but I want to spend the majority of my time talking about testing results. Before we were worried about testing, now we have to look at the results and see what kind of results we're getting. So this is basic stuff from last week. There are two ways to do viral testing. The first one is what is going on today? What is going on now? At what stage of a disease might you be at? So those are the tests that are I think you've probably heard them on TV, the reverse transcriptase, or the ones that take a long time. We'll talk about that in a minute. And then there's what happened to you ago? At least 3 weeks, possibly longer in your life. What happened to you before? These are sadly somewhat easier and faster to do. They're based on the quality and the quantity of antibodies you make. And so those tests are what happened to you, this is now April, what happened to you in late February or in early March, but they're not going to tell you much about what's happening today. So the next slide, please. I'm concerned more than anything else in the laboratory with getting the best answers. So the best answers are a cooperative situation between you in terms of the patient giving us the sample, the actual test itself, and then moving that answer out to the most appropriate physician for you. So here's a few caveats about the nasal swab issue. It can't be done by an amateur. So any thought that you might have of at-home testing with a nasal swab is not going to work. You cannot touch the upper part or sides of the nostril. That's why they have you bending, I can't help myself, all the way back so that they can put the swab in somewhat straight. It has to go all the way to the back of the nasal passage. That's what causes the gagging that you see and the face that everybody has with the corrected and correctly placed swab. If you didn't feel that, if you didn't want to go at the end of it, then you might have to do it again because we didn't pick up the correct amount or position of that swab. So we want to get usable answers, and the best way is to make you uncomfortable. I think I probably shouldn't have said it that way, but that's true because a bad specimen is going to give you incorrect answers. If we can go to the next slide, I will talk about the same thing briefly in terms of the throat swab. If the throat swab doesn't cause you to cough or gag, it didn't go back far enough. This organism is not found on the teeth or on the hard palate or in your tongue. It's got to go all the way back. This particular test that this swab is dealing with, and that's all that's happening at these so-called testing centers. They're not testing centers, they're swabbing centers. That swab has to be put into a special transfer media and sent to the laboratory. So it's going to take time for that specimen to get to the lab. And then if you look at these, I'm not going to go through them individually. Each individual specimen is going to have to take time to be treated, to be tested, and then to be interpreted. So even if you get there first thing in the morning, you're not going to get an answer for at least 5 or 6 hours, maybe longer. Some hospitals do not have the facility to be able to do these tests, and that means those swabs are going to have to be transferred, hopefully nearby, but in some circumstances, it could be in a couple of states. So the test specimen doesn't even get to the testing lab for a day or two. That's the reality of our lives right now. And another reality of this life is there are a lot of hospitals that are running out of swabs, that are running out of that isolation media, and they're now trying to make these on the fly. So that may actually be an additional delay before the answer gets there. The next slide, please. Okay. And again, just a little caveat on all of these. The people that are taking these swabs for you, the people who are collecting the specimens, are out in rain, in the snow, maybe in the heat. They've been out there for days. They're exhausted in many instances. They may tend to forget things. The laboratory must have a swab that is completely labeled. There are 2 Susan J. Leclairs that live within 3 miles of each other. I checked. So it can't be just Leclair on that swab because they don't know which one of us. It can't even be Susan because there are 2 of us. She also has J as a middle initial. So it's got to be the full name, your address, your date of birth, the name of the physician so we know who to contact to give this information. And that adds a lot of frustration to everybody. For you when you hear the news, and for us when we have to say, I cannot use this specimen because it is incompletely or incorrectly labeled. Now that's true for all specimens, so that was just an aside. This is for the second set of tests. This is the antibody test. And the only thing that I want you to get out of this slide is that antibodies don't happen first. When you first get a disease, it is the cellular component that's important. Your neutrophils, your monocytes. It takes the lymphocytes time to be able to figure out, is this an antigen that I need to do something about? And if it is, what am I going to do? So we don't find IgM, the very first antibody, till maybe 8 or 9 days into the process. If you think of a common cold, that's when you start feeling better, is 8 or 9 days after you get the cold. The IgM is only there temporarily. It'll stay for about, 10 days to maybe 20 days. IgG, which is a longer acting antibody, doesn't begin really until the 2nd week, and in some instances, maybe even the 3rd week. And that will give you a much more prolonged, much more complete recovery if you have that IgG. So if you're asking somebody, can I get an antibody test? If the antibody test is for IgM, you can get it in maybe 9 to 10 days. If you're asking for an IgG production test, that's going to be longer. And for many of you with CLL, your production of antibodies is less than superb. So these numbers, the green chart and the red chart on this slide, those may be pushed back further and they may be lower, which means you might not be able to get as strong a reaction in the test as you should. Next slide, please. Oh, okay. So the thing that I want to talk to you about is false positives and false negatives. And maybe this one I can do it with. If you're doing an antibody test and you want it done the day after you got the disease, it's going to be negative. You didn't make any antibodies yet. If you want an IgG test 14 days into your disease, maybe you've got a whole 5 antibodies that have been produced at that point. It's not going to be able to be tested positive. You don't have enough of them. So one of the problems with this is that all of the timing of these diseases has to be done when the antibodies are there. Now, what about the viral testing itself? I think lately you've been hearing a lot about false positives and false negatives. So let me try and do some math for you. pretty good tests usually have 1% false negatives and 1% false positives, which means if I have 100 random people, one of those people is going to get a wrong, or maybe two are going to get a wrong answer. That's part of the reason why there has been such a clampdown on who needs to get the testing. We want the testing to be done on people that we're pretty sure may have the disease, because then we're not going to falsely tell someone that they have the disease. Now, why is that a problem? Because as Dr. Mato or Dr. Brander will tell you, beds are tight. And you don't want to bring somebody into the hospital and take a bed for a person who's really got the flu or who's really got some other disorder. And okay, 1 out of 100, we're testing 1 out of 1,000, that would be 10 people. We're testing 10,000, that would be 100 people. These numbers grow very quickly. Similarly, for the false negative, let's say I have 1 false negative in 100 people. Well, that doesn't sound too bad. I don't get to interact with the physicians. I don't get a bed. I don't get extra stress put on the hospital. No, what do you get to do? You get to spread the virus around more because you think you're healthy. So timing of these particular tests is critically important so that when you say to your physician, I want a test, and he or she says, not now. It may be because you're in one of those places where you don't have enough antibodies to be able to give them a firm answer, or you don't have the signs and symptoms that would justify using a test. I know everybody wants to get tested, but if you test me today and I'm negative, does that guarantee to you that tomorrow I'm going to be negative or the day after I'm going to be negative? So allow your physicians to make the decisions of who is the most appropriate person to be tested and more importantly, when they should be tested. And having dumped all of that responsibility on physicians, I am now pleased to introduce Dr. Meadow, who will probably say that they don't want many people tested at all in certain circumstances. Dr. Meadow.
Hi, Anthony Mato from Memorial Sloan Kettering Cancer Center. In the interest of time, just happy to be here, and I'm going to pass the torch and introduce Dr. Danielle Brander from Duke University.
I'm at the Duke Cancer Institute. Happy to be back again this week. And as Anthony introduced us last week, we are hoping to provide expert opinions from the CLL side. Though certainly not claiming to be COVID experts myself. But again, thanks to everyone for coming back.
I'm going to start with, I'm going to lump some questions together, and I'm going to throw this out to the 2 doctors to begin with. Masks. There's a lot of controversy about masks. Rather than addressing maybe the public policy issues, could you talk about what you're advising your CLL patients about whether we should be wearing masks if we have to go out? Obviously, we're trying to stay at home. Dr. Brander, you want to start with that?
Sure. I see you have me starting with the easy questions here.
Oh, is it easy? We'll see.
No, I mean, this is a very important question. I think there are a couple issues just to point out. One, of course, with mask wearing is, what is the purpose? Is it to protect the individual wearing the mask? Is the purpose to protect the other people around someone that is wearing the mask? There's also the issue of there are different types of masks. And finally, an important point I think that's come up, and now there are resources available online, is what are the proper ways to put on and take off a mask? We obviously, I believe if we're going to be doing it, you have to be done correctly. And though outside the time constraints to go over that, I just want to make those couple of distinctions. As you mentioned, in terms of policy, there are changing recommendations and there's changing data. I think many of our patients, I've noticed just from my experience, have been wearing masks and have their own masks. And again, if you're putting it on properly, taking it off properly, I think it is fine for patients to wear, if anything, maybe helps keep distance. Just again, look up the proper way to put them on, proper way to take them off, and continue to do all the other things you're doing, like good hand washing, social and physical distancing, all those things, because we don't want to falsely believe that a mask, particularly a surgical mask. And when we say surgical mask, we're referring to the thinner masks that often loop over the ear, and just don't want to give a false sense that that protects you from everything that is coming in. However, many institutions, myself included, have healthcare providers wearing these type of masks even for day-to-day encounters. In that case, there's evidence of different respiratory viruses. Again, we're pretty early into the SARS-CoV-2 to know the full extent, but just looking at other respiratory viruses, of trying to prevent as much as we can either droplets or aerosolized particles to others. And therefore, I do believe we have a part, as long as it is able, to try to prevent the asymptomatic spread of things. And that's going to vary place to place. Now, people, the last variable I'll just mention is particularly for healthcare workers or providers that are in close contact at high exposure or certain procedures, the importance of personal protective equipment in those settings might be different. But yes, I think for patients that have it, if you're doing it correctly and just remembering it's not full protection, that can be very helpful. And then I'm glad to see that we're starting to be able to do our part in trying to prevent asymptomatic spread to our patients.
And, just a follow-up question on the mask here, and can you reuse the mask? Can they be, people are asking, is there a way to clean them? Can you microwave them? I mean, there's just all kinds of questions about this because of the shortage of masks.
I think those are excellent questions. That might be something we can, just talking on the fly a little bit, try to put together where those resources are rather than go over them. I know a lot of institutions have rolled out very quickly protocols to systematically study this. How do you try to sterilize them? What is safe for healthcare workers to reuse? I know at Duke and other institutions, they publish that in a way that they're trying to study it. So that might be something good we can put together. Certainly not all are created equally, and you can't assume a way you might sterilize something else is not going to affect the integrity of the mask. The CDC and others have kind of listed the I guess, I don't want to say quality, but the rank listing of things to use, but I think sterilization needs there too.
So we'll put together some resources and get that up on the website for people. Dr. Mato, one of the questions that comes in a lot of different forms is, I have CLL, and am I at particular risk if I'm mutated or unmutated, if I'm on a monoclonal antibody, if I'm undetectable MRD, if I'm in watch and wait, if I just had chemo in the last 6 months, if I'm on ibrutinib, and if I'm on venetoclax. I mean, are all CLL patients at risk? And I know that you don't have full answers on this, but can you give us a sense of that? Because there's a whole spectrum of CLL patients you see.
I think it's a great question. I think there's two different ways to try to approach it. The first way to think about that question is, are CLL patients at a higher risk of acquiring COVID-19 than the average patient the average person in the community? I would say at this point in time, given how contagious the virus is, I don't think of CLL patients as being at a higher risk, but I think of all people being at extremely high risk for acquiring this virus when they come into contact with it. but CLL doesn't make you at a higher risk of acquiring the virus. The second part of the question is, if I have CLL and I acquire the virus, and am I at a higher risk for developing clinically significant adverse outcomes associated with the viral infection? It's a question of study at this time, but I think the general assumption is that anyone who's immunocompromised, and that is any patient who is RISE stage 0 all the way through treated, is probably should be considered immunocompromised, and therefore may be at a higher risk of developing more clinically significant complications. So I think the risk of acquiring it's probably the same. The risk of having complications may be higher, although until we have broad epidemiological studies that will likely be concluded after this crisis is over, I think we're just going to have to assume that the risk of complications are higher. The risks of complications are higher.
Dr. Mato, we're doing some research to look at these issues in terms of how patients should be managed. But do you have any kind of general approach about if you're on medications? And we know that some of these medications, even the targeted therapies, can suppress certain counts. And do you have advice to patients about staying on their meds if they're getting infusions? I know each case is going to be individual, but what are you advising people generally in this?
For patients who don't have an infection who are on targeted therapies, I'm not planning on stopping anyone's therapy just because we're in the midst of a crisis. Most of the targeted therapies that we have are pills, and so it's just a question of verifying that the supply is in place, which we've already talked about, that doesn't seem to be a problem in the US, and that the patients have access to the medications. For infusions, I think there's a little bit more of a debate about whether those should continue or not continue. I think the answer is you have to consider the risk of acquiring the infection in addition to the risk of the disease being well controlled. If a patient has had 5 of 6 cycles of bendamustine rituximab and they're in remission already, it's very reasonable to delay those last cycles of therapy or last cycle of therapy. If a patient is early on and requires an infusion in the setting of poorly controlled disease or Richter's transformation, for example, then I think the risk of potential exposure at the center is worse or less than the risk of having a life-threatening complication from the disease. So for uninfected patients, the standard of care, I think, should be to continue their therapy, particularly if they're oral targeted therapies. I don't have any data to say that if I stop ibrutinib today, that I'll restore their immunity to some level that will be protective for patients tomorrow. So the other question is, once a patient is infected, whether or not medication should be stopped. I think the general rule of thumb is that cytotoxic chemotherapy should be held. Infusions with anti-CD20 antibodies should be held in the midst of an active infection. Certainly, we don't want those patients to be able to come to the center if they are actively coughing or have active symptoms at those times, unless they require supportive care. The question of debate is whether targeted therapies should be stopped, like BTK inhibitors or BCL2 inhibitor like venetoclax. There's no firm answers, but the general take from the CLL community is we have to balance not only the immune system, but their disease. And if a patient is infected and clinically stable, it's very reasonable, in my opinion, to continue their targeted therapy and observe them. Obviously, if there's a deterioration in symptoms, you make a decision on a patient-by-patient basis.
That sort of gives me a chance to switch to asking, there's a lot of questions about IVIG, and I'm just going to ask like a basic one here to Tom, and then I'm going to have Dr. Brander and Dr. Mato kind of jump in here. Tom, had some questions about storing the subcutaneous IVIG. People are considering doing that at home so they don't have to go into clinic. Could you talk about that? People had some worries about that.
Well, sure. So the subcutaneous form is the only form that's authorized to be used without supervision, either by a physician or a nurse. And what I mean by that is, obviously, it has to be prescribed by a physician, but you can do it in your home without having to have a nurse check on you on a regular basis. I was surprised to find out that there are actually 7 different brands of the subcutaneous form, and there's 4 different storage recommendations on those products. So typically with the subcutaneous immune globulin, at the time of manufacture, they have about a 36-month stability period or an expiration time. And most of the drugs say that you can keep it in the refrigerator for that length of time. So whatever the remaining amount on the expiration date would be the maximum amount of time that you could keep them in the refrigerator. There is one product that can be stored at room temperature, and that's a product called Hizentra, and that can be done 30 months at room temperature. But all the others are shorter periods of time. I will say that they all say that if you do store it at room temperature, not to return it to refrigeration at a future date. So I would suggest that you speak to your pharmacy and to your provider to make sure you know which brand that you are receiving, and then do some research on or ask your pharmacist or your physician for what the storage recommendations are for the individual brand that you are receiving.
Dr. Brander, on the use of IVIG, if somebody's already getting it, let's say because they've had recurrent infections, and do you have advice? And tell us a little bit about, I know, about how it's used to prevent or maybe to even treat COVID.
Sure. That I think in general for patients with hypogammaglobulinemia, or usually you look at low IgG levels in terms of infection, there's certainly different scenarios. The one where we generally start talking to patients outside the COVID-19 era about whether use of either subcutaneous or intravenous immunoglobulin could be helpful is if patients both have low levels and a history of recurrent infections such as sinus, bronchitis, urinary tract, etc. Many of us have seen patients who might, as part of a study or otherwise, have screening IgG levels done, are known to be low, but do not seem to have a problem with recurrent infections, in which case we generally don't start. So I don't see any evidence right now to start patients with low levels or patients with CLL without known levels on immunoglobulin replacement. I think that's the first point. We have no evidence to start patients new. For patients that are already receiving it, I think, again, similar to what Anthony mentioned for continuing therapy, is it's balancing the risk of getting the, if it's IVIG, at the center for that given patient versus waiting. And what I mean for that is you could consider spacing it out if the infections were a year ago, but patients were continuing. Maybe instead of every 4 weeks, they could go to every 8 weeks if the infections haven't been recent. If it was recently started because of difficult to resolve chronic significant infection, then I think for patients, we've been trying to continue that as much as possible because it was a recent reason to initiate. And for that given patient, I don't want to exchange one risk for a known active risk if they have an active infection that you're trying to help augment the clearance of with doing the therapy.
Dr. Mato, do you want to add anything to that?
No, I think I completely agree with what Dr. Brander said.
There's talking again about these immune response. There's something called convalescent plasma, which is, I understand they take antibodies from people who've recovered. Susan, can you just briefly explain what that is and why that might be hopeful and what some of the drawbacks to it are? You're muted.
I think the big issue with convalescent plasma is that we don't know. It is typically IgG because it is that further on down the line type of immunoglobulin. The problem is it, will it, could it be protective? You make an IgG antibody for the common cold and it's protective for about 4, maybe 5 months. That's not really the type of protection I think people are looking for when they're talking about a protective antibody for COVID. They're looking for something more like against whooping cough, which is years, maybe even decades long in its protection. I don't think there's been enough fact out there. There's a lot of studies that are going on. There's a lot of interest in this, but I don't think there's much fact out there as to how long this IgG is going to stay around and if it is protective. If it is protective, then there are a whole other set of circumstances of, can we get it from the plasma from volunteers? Is it stable enough to turn into some kind of infusion and all of those kinds of things? But right now, I think the answer, as with so many things about this disease, is not yet. We just don't know. We're hoping, we think it could be, but could be is not the same as shall be.
Tom, I'm going to give you the easy vaccine question here.
Sure.
And I'm going to give the harder one to the doctors. Routine vaccines, the pneumonia vaccines, the flu vaccine, in now, or should we still be getting those now?
So, you know, the influenza vaccine typically in this hemisphere is given from October till April. So, you know, we're probably past the period of exposure to influenza, you know, because it takes about 2 weeks for you to develop immunity after that immunization. So I would say that, you know, the flu vaccine is probably not something that, you know, patients should receive at this time. But, you know, most of the CLL docs that I've spoken with recommend that their patients receive the influenza vaccine on an annual basis. So coming next season, for sure. The pneumonia vaccine is definitely recommended as well. What we want to avoid are any of the live vaccines. And so before you get any vaccine, I think it's important to speak with your CLL provider and make sure that they are comfortable with you receiving any type of a vaccine. I think another one that's frequently recommended is the shingles vaccine. And, you know, to avoid that recurrence of that virus flare-up.
There's a lot of talk about vaccines coming. It won't be this year, it'll be next year if everything goes well. One of the concerns is, as Tom pointed out, is we're not supposed to get live vaccines. Are the vaccines that are being developed going to be killed, and will they work with CLL patients? Dr. Brander, Dr. Mato, either one of you want to take that?
Sure, I can start. I think a couple things just to be said about the vaccine development is the big takeaway is that there's actually multiple different candidate vaccines being looked at. So yes, some might not be, some might be live candidates, but there are a lot that aren't. One of the ones that made press or the news for being tested or starting the clinical trial part of it a few weeks ago was not a live vaccine, but targeted at a protein on the virus called the spike or the S protein, and it was a different method than having, for example, the body try to recognize live virus. But the biggest takeaway, I think, is that in terms of hearing the long development timeline, and as well as patients with CLL will be able to eventually receive it, I think the biggest takeaways are, number one, the areas that could be done as fast as possible to look for vaccine candidate, I think were done very quickly, which was distribution of information to understand the virus, to develop something and to start using it in clinical trials, so when it was being tested in patients. But the part that now is still going to take 12, 18 months or longer just can't be bypassed, because there are things in vaccine development that have to be looked at in terms of safety, that you just can't rush the body and the immune system, and that follow-up information for all those that have participated in other clinical trials, you know the amount of detail collected. And in something like this, where you're talking about offering it not just to patients with the risk that they could have active infection and you're trying to treat the active COVID-19, but you're talking about in terms of vaccines, trying to give it to a huge group of people And so the safety part and the safety collection and what the immune system is going to do just cannot be sped up. So I think it's hopeful that everything that could be sped up was, but you can't bypass this part. And that's the safety part of it. And then in terms of efficacy, one of the reasons there are so many different candidates, I think, is you just don't know what's the best way to approach it. So people have, and research groups across the globe have, I think, disseminated information, and now people are trying to approach it. Do you try to go after this protein? Do you try to get the body to identify it? So there are multiple different candidates, and I'm hopeful in those, but the time of that is still spread out, and that's why a lot of research is looking at trying to use, for people that develop infections, how do you treat that? How do you dampen consequences of the infection?
And I'm just going to add, because we've got a couple questions here just following up on Tom, the pneumonia vaccine will prevent particular complications. Some of the problems with COVID is that people get secondary bacterial infections, especially if they're on a ventilator, and it'll prevent certain kinds caused by the bacteria that protects against. It will not protect against COVID, and it won't protect against a lot of other bacteria, but that particular, which is a very common cause of pneumonia, which is why it's called the pneumonia vaccine, will help with that. So if you're not up to date with that, it wouldn't be a bad idea to do that. There was, Anthony, you talked a little bit about inflammation being a factor here, and there's a lot of questions about that in all different kinds of ways. Like, is the fact that we're somewhat immune compromised a potential advantage, and that we won't get all these cytokines, these toxic chemicals released? And I know that they're using even some of the same drugs that I had when I had my CAR T therapy and had the cytokine release syndrome. They're doing trials on the drugs that block the interleukin-6. And I wonder if you have any thoughts on that. I know, again, we don't have any data, but these are areas that are being actively researched.
I think it's a great question. I wish I had some data to support that. Certainly the virus itself isn't killing anyone. It's the body's response to the virus in terms of inflammation, which can either be your best friend or your biggest enemy, depending on how much is present in response to an infection that causes the cell death. It causes the organ dysfunction, particularly in the lungs, the heart, and the vascular system. So a little bit of inflammation is a good thing because it does clear infections. A lot of inflammation is a bad thing because the the body can't handle that. Whether CLL patients who have dysregulation of the immune system are in a better position, I think, is unanswerable. And just thinking about it a little bit more, I think the reason why I say that is that CLL is in some ways a disease of immunosuppression, and in other ways it's a disease of autoimmunity. And we have many patients with CLL who have autoimmune complications. Sort of the immune system is hyper activated, like autoimmune hemolytic anemia, platelet count issues, other autoimmune complications. So just to say that having CLL is protective, I think it's probably not true. Whether some of the drugs that are used for treating CLL, like BTK inhibitors, for example, may protect patients from, or at least blunt that inflammatory response, I think remains to be seen. It's being asked as a research question. Would I stop a BTK inhibitor, for example, on a patient who's got COVID-19? I think I already answered that. Would I provide those medications to protect patients with CLL who didn't need treatment anyway? Absolutely not, unless it was in the context of a research study. So I think, unfortunately, again, the epidemiology and analyses of outcomes of COVID-19 in the setting of other, various comorbidities will just have to be studied later. But use of CLL medications for treating the disease is an interesting question. And again, we won't have data probably until this crisis is nearly over before we have that answer.
So I'm going to ask a series of questions about the precautions that are particular to CLL patients. So one that's gotten a lot of press lately, generally, is about how you handle groceries delivered. We're assuming we're all staying at home. So it ranges from everything to, you know, leaving stuff for 3 days and sitting there and sterilizing and spraying everything down and saying, don't worry about it, just, you know. So I wonder if you have, what advice you're giving your patients about picking up groceries, picking up the newspaper, you know, picking up the mail, you know, all, you know, give us a sense, is the packaging more dangerous than what's in the packaging? If you could, maybe Dr. Brander, you could start with that. What advice are you giving your patients who I bet are really nervous about this?
Sure, and very great question. And like we've said for other precautions, I'm saying the same to the caregivers of my patients with CLL, and honestly, a lot of people in general, I think, for precaution-wise. In terms of food, it's a lot of the information to date that's out there looking at the food science is that it's not, there's been no evidence that this is spread in food itself. So when people think of getting food poisoning of bacteria or other things in the food, there's no evidence that this grows within certain foods. So that the food itself, like inside of it, is not harboring the bacteria, or that it's being spread multiple ways that way. So as you mentioned, I think earlier in the program, as much as possible, what are the ways to protect and getting food? Because we all at this point need to get good food into our homes. And I think as much as possible for patients with CLL, if you can have a consistent someone else either bringing food to you or food delivery or drop-off options, what that takes out of the equation is having to be prolonged in a store with maybe other people that are infected or don't know that they're infected and shedding. So I do think there is value to drop-off or delivery of food, or if you're having a consistent person versus, 20 different people from a social setting bring you your food, you kind of know it's consistent. In terms of what to do when the food is there and brought to you, again, I think we have to, understandably, this causes a lot of concerns, but have to take a step back and know what we know about food safety in general. So you don't want to switch the other way. Now it's getting warm out. You don't want to leave things that would perish otherwise sitting out to get rid of the virus on the surface, and then have not safe food practices for other things that can grow in food if it sits too long or warm. If you're getting delivery or takeout, I think as much as you can, it doesn't hurt to take it out of the package onto something else, probably needs reheated anyway. And then you're taking away the concern and maybe allowing to enjoy a little bit more the food, knowing that you've kind of removed probably what is the greater risk, which is whatever it's the container or whatever it's coming in. And then lastly, just look and ask ways that the exchange of that, either food delivery, takeout, drop-off, can be done without having to sign tablets for payment, or leave a message that says don't need to ring the doorbell. I mean, you ordered it, it's probably coming. Those kind of things. But just again, always remembering, still want to follow normal food safety and not allow things sit out that could perish and cause other problems.
Anthony, I'm going to give you the tough questions. I think we would all agree that if you're a CLL patient at any stage, mutated, unmutated, watch and wait, whatever, and you're a healthcare provider on the front lines, whether that's a physician, a nurse, a physical therapist, I'm getting questions from all different kinds of people. It would be best not to go to work. Would you agree with that? Is that what you're telling your medical professionals who have CLL in this time?
I think in general, at least at the height of the crisis, it's reasonable for patients with CLL who work in crowds, whether it's in a hospital or some other venue, to stay at home. Certainly for our patients who are requesting letters for support to work from home, we're giving them out to patients, regardless of what their profession is. So I do support that. I think we've all proven, physicians included, Dr. Brander and I are good examples of that, that we can work from home and still function in a medical capacity. So I think that, yeah, it's reasonable to stay at home, at least at this particular time.
So let me ask the tougher follow-up question. Your partner is a physician or a nurse, and you live at home with them. So what are you, or I can give a real example, someone whose husband is the chief medical officer and an infectious disease specialist in a hospital in Long Island, you know, and he's going into work every day and seeing COVID patients every day. What advice are you giving people about their partners in these circumstances?
There are many hospitals that are providing support in the wake of, like, hotels, for example, or staying closer to work while people are on their shifts or their rotation. So that may be one option, to stay away for a little while. I know colleagues who are doing things like that. If you have to come home, then certainly, you know, good practice, immediate washing, taking off the clothes, keeping separate laundry, immediate shower, you know, any exposures to obviously isolate or stay at a different location. I mean, if you have CLL and your partner, your spouse has to work in a healthcare situation, obviously we need our healthcare workers to be able to go to work, but probably does require some special precautions by either staying away or more separation in the house, or at a minimum, you know, extensive changing of the clothes and washing upon walking in the door. I think you and I talked about this at another time point. This may be a good use of changing in the garage or taking off the clothes in the garage before you walk into the house. Depends on your climate. In Dr. Brander's neighborhood, you probably can do that before you walk in the house, a little earlier in the season than up in New York. But I think that's, you know, it's a reasonable way to be, given that, you know, you don't want to bring this into the household, especially if they're immunocompromised patients. You know, Danielle, do you have any additional advice?
I agree. I think in a slightly different but question asked last week, and I thought a lot about this and yours and others' great advice. And I think just one last point to add is that everyone's different in what your needs are too. If you're dependent on your caregiver for cooking, or you have other health problems, then living apart might cause more problems or stressors, again, adding this risk. And so focusing, what are the things that you can do? If you have a spare bedroom in the house, maybe that limits, so that you sleep in separate bedrooms and live in the same house, then it limits some of the close proximity, wiping off the surfaces that you can wipe off, et cetera. And if you have questions, you know, we're always happy to answer them. But I think a lot of us are if there's comfort in knowing what healthcare workers are doing in general, even without a patient that's immunocompromised in the house, I think a lot of us working in healthcare are trying to do these measures ourselves to try to prevent spread amongst our family or friends, both ways, to keep us healthy, so that I can come to work when I need to help patients and others, and then not be here when I don't need to be here. And as Anthony mentioned, just thinking of ways, most of us have switched to washables or scrubs at work. I mentioned the mask part, the contamination in the garage, but for those that have a partner or caregiver that is going to work in the healthcare setting, just try to focus on all the things you can do, and some options it might be living separately. But for some situations, it's okay if it can't be, because you're dependent and it might cause more stressors or health problems to be trying to live apart. And financial, that's the one last thing that I'll say is, you know, I think these are all recommendations to try to think of all the ways that we can do, but we recognize that for some, the nature of your job or just resources, that there are a lot of things that you can do if living apart or taking a break for work is not an option, that we recognize that in some cases it might not be. In any way we can help, please let us know.
So I got a little bit of push, and I'll push you on this, Dr. Brander. people are wondering about the paper, you know, the cardboard, the boxes that things come in, the mail, the newspaper. Can you can't really spray those down. What are you recommending in that regard?
Well, first is recognizing what we don't know. Some of the studies looking at surfaces, this is an RNA virus, might test for RNA particles. We don't know if you detect that, does it really mean that it's an infectious particle? Maybe I'm not saying it in the right way, and Dr. Leclair can jump in. But studies that look at, swabbing different surfaces might not get at the infectious part of things. I think, again, if it's a cardboard box with something inside and you have a way of that can safely sit somewhere like the garage, it's not a perishable inside, then that's fine. Or if you have gloves or a way to wash that when you take something out of it or out of the box, that you don't have to bring that extra cardboard into it. I know Dr. Leclair mentioned last time when they had a newspaper, the waiting to kind of shower or wash off afterwards. But I think the key is when you hear conflicting studies, just recognizing picking something up might not be the same as an infectious particle, but the virus is very killable, sensible to 20 seconds, I almost said 20 minutes, that might be a lot, 20 seconds of warm water, hand washing. Watch those videos online of surgeons, or I've seen where people put like black ink on and when you normally wash your hands versus how you have to cover the back, the crevices, nails, etc. Doing that before and after handling it, or especially just any practice before and after eating because you're putting your hands in your mouth, which we probably should be doing anyway. But even if you can't wipe them down, my point is, I think the hand washing, anything that's on it should help kill it.
I also recommend, wearing gloves to the mailbox is not unreasonable. And unless it's a bill or a check, I suggest to throw it out immediately. I mean, there's so much mail that we don't need to filter through, but even personally for cardboard or these types of things that are coming to me directly, a quick wipe down is not a bad idea on the exterior surface, even of an envelope before you open it up or handle it. But there's a lot of mail you can just discard, and it just a few that you have to deal with.
Susan, the Dr. Mato mentions about gloves, and in your profession, like a physician, gloves are mandatory in most of what you do. But there's more to gloves. It's not just the gloves; it's how you put them on, how you take them off. Could you walk us through that a little bit?
Well, I think the brief answer to it is that most people put them on and take them off painfully, because the whole idea about a glove is to make it as closely fitting to your hand as possible, which means it's difficult to put on. So if it's the first time that you're doing this, welcome to the club. We've all had it. The idea of putting it on right now is just to make sure that it's usable for you. So if your hands are small, don't get the extra large, get the small and fight with them. The big issue when you put them on is to make sure that they're down and that you haven't cut through with fingernails or rings or other things like that, because that just kind of defeats the purpose. The big issue isn't so much putting them on as it is taking them off. Because now let us say I do have gloves on and they have been contaminated, or at least I don't know if they've been contaminated. How do I take them off? Because they're tight. How do I do this? And one of the easier ways to do this is to hook one finger inside. I'm left-handed, so everything has to be thought of backwards. To put your hand in the cuff of it and pull it off. So now the inside of that glove is the contaminated, and the outside of the glove as you touch it has been next to your skin. Use that glove then to take the second one off. Do it immediately in front of a trash can. Let it go and let them drop in. Never touch them again. It's kind of one of the easier ways to do it. And providing that you don't have very long fingernails, or that you don't have extraordinarily rough hands where that might cause a problem with just putting them on. You might rip the nitrile, that these would probably be the easiest way to do it. You may want, in frustration, to just grab them by your teeth and pull them off, but that's not a good idea. You need to take them off, pulling them off out, inside out. And that will help you.
Brander, anything to add on gloves?
It was a great description.
Yeah. Okay. We're going to do the post questions right now, and then I'm going to come back and ask the doctors about routine visits and what's going on with trials, because I think that's been updated a little bit since the last time we're here and what the status is. So if you could just take a few seconds now and go through, it's the same 6 questions, or actually I think there's 5 this time because we already answered the first one. And if you could just, let's take a look here compared to last time. So I think people have a better understanding. That's jumped up from, so, you know, I think overall that number there was, take a look here, was 47%. It's up to 67%. And in the second, we've got 90% of people, I think, understand about testing. That's also a jump up that's considerable. This is, I think you made an impact, Tom. I think people are less worried about the drug shortages now. In the anxiety, I don't know, did we impact the anxiety or did we make people worse here? I think 42 were strongly anxious and 44 were, you know, agree. So we kind of shifted it a little bit. People are maybe a little less anxious. And what big changes are you going to make? Let's see. I think those are pretty similar in terms of what they're doing. More people are going to stay home now than before. So I think those are all really positive changes. So I'm very grateful to our panelists for that. Let's talk a little bit about trials. I got questions about specific trials, and you can't answer those because there's so many of them. But last time, Dr. Mato, you said that you were trying to make individual decisions, but and maybe that's the case at Memorial Sloan Kettering. But I'm also hearing that some trials are closed and it doesn't matter, you can't get in. And what's happening if I'm in a situation where I'm about to enter a trial, or I'm in a situation where I'm in a clinical trial? What's happening these days for CLL patients?
I think what I said last week, I think does still stand, that we're making individual decisions for patients based on what the appropriate standard of care would be in that situation. Just dissecting it a little bit more, in the frontline setting, in the setting of this crisis, I'm not really sure that there is a strong justification to enroll somebody in a clinical trial if there is a good standard of care. Certainly we have so many targeted agents approved. We have ibrutinib, we have acalabrutinib, we have venetoclax as targeted therapies. So, but in the relapse refractory setting and in the setting of Richter's transformation, when patients have been treated with multiple lines of therapy and there may not necessarily be a great alternative, I think it is very important to maintain clinical trial options for patients, because you know, what I said last week also stands. This crisis will end in the scale of months. CLL for everyone is a long-term issue that is, you know, likely will be dealt with over the course of someone's lifetime, like other chronic medical issues. And so it's always, the goal is always to provide what we think is the best therapy for the patient at that particular time. And so in my own practice, and I'll be curious to hear what Danielle says, we have kept our clinical trials open and available to patients, and we weigh, you know, what is a good standard of care option. If one doesn't exist and the trial is the best option, we're happy to enroll. But what I will say is that we have had the fortunate guidance from the FDA, from the sponsors, from our own institution, that many of the procedures that needed to be done and some of the monitoring issues that needed to be in place prior to COVID-19 are now less stringent. And so it may require less frequent visits, less time at the center to try to avoid exposure, but we're certainly still able to enroll. And I think I'll pass it to Danielle to hear her take.
Yeah, largely agree, and we're doing similar, though at a different stage than New York City. Obviously, right now, trying to do similar and get ahead. I think a couple of things. One, when people hear about a trial being closed to enrollment, I do just want to distinguish between a trial being shut down. When you hear that word, and to my knowledge, people aren't being taken off trial therapies that they were already part of the trial. In some cases, in certain maybe very involved short-term risk, people might put off consent and enrollment for a period of time in a given trial if patients feel they can kind of safely make through that. But at least to address people that might be concerned of a trial just being shut down and being taken off therapy, I'm certainly not aware of any of that being discussed, because the goal of all of this is to keep patients informed and protected as much as possible from getting COVID-19, but also keep them getting as best a care as we can give for their CLL. In terms of frontline, the one thing I'll add to Anthony, we very much as well, because there are multiple frontline options available, I think that's a scenario where we're not really new enrollment to clinical trials. And one other thing I would add for patients, if maybe you were considering a frontline trial looking at combination therapy, and we're now talking about single agent, a lot of what I'm trying to tell patients is what we decide to do right now, and there's lots of good options, doesn't mean down the road you wouldn't add in a combination, or it's not going to prevent us from thinking ahead of what is we're trying to balance in the short term, what's the safest. And there are so many effective frontline therapies as monotherapy that starting as that doesn't necessarily mean that's the final treatment plan, trying to balance the two things of really good options for the CLL versus maybe longer term, what might be done in combination or adding agents for doing combination therapy or defined courses of therapy, that, et cetera. So what you start now in that risk might not be, months from now, what you might end up talking about doing with your individual oncologist. But by and large, yes, it's a case-by-case basis, and everyone has been at our level, and certainly colleagues, really advocating to keep options open for patients with CLL that's relapsed, or Richter's, or situations where we don't want to compromise having those options available for the best care possible.
And would both doctors still agree with that they're trying to do more on the phone, more with allowing patients to not come in to get their trial medications or the regular medications, more with telemedicine where possible? Is that still something that's being rolled out more and more at your institutions?
Yes, certainly for us. And I think in the first weeks, there was a little bit of, well, should people be postponed or do a telephone visit now? Certainly right now, the approach I'm taking is not trying to postpone as much as trying to see the scheduled visit and switch it to a telehealth visit. So we do what we can at that point. If someone needs labs, but the rest we think we can talk about later, then maybe they get labs locally or get labs and leave. Again, I think every touch point that you can reduce is a good one. So even if you need labs, you might not need to wait in the waiting room or in the office visit. So I think that's a big opportunity, and I'm sure Anthony maybe can speak more to it.
I think one of the lessons that's coming out of this whole experience is, and I'd love to find a way to study this, is what exactly do we need when we're not in a pandemic for routine care of patients? And I think we're all getting a crash course in how much, what the appropriate frequency of labs should be. How do we minimize exposure to patients to a medical setting? And I'm sure this applies to regular flu season as well sometime in the future. How to do telemedicine. I had absolutely no experience until 2 weeks ago. Probably Brian had more experience than any of us, because I know the CLL Society was doing that already. So it's a learning process. I do think from the perspective of research, we are doing a lot of telemedicine visits, shipping of drugs, local labs. deferring response assessments, and a credit to the sponsors or the pharmaceutical companies that are funding these studies, that everybody has been very flexible in allowing some leniency on the protocol so that we can get the best therapies to patients, but at the same time not expose them to unnecessary testing or visits. So I think in the future, we'll probably learn the lesson after this crisis is over on how to maybe in some ways more efficiently manage patients and minimize the number of tests, but yet still do a similar job or do the same job for them.
Yeah.
Go ahead.
No, I was just going to say, and I hope the advocacy can continue to follow Anthony's comment of what we can do remotely, and that insurance or other companies don't hold us to when things are in the best interest of patients.
So I'm going to I'm going to save the final question here, and then I'll ask everybody to wrap up. But I'm going to say that my wife Patty put in, because it's about me. And I just like the two doctors to weigh in on this. But it's also a question that other people asked, and you talked about infusions and maybe putting those off. What if it's IVIG? How do you make that decision if somebody's their IVIG? Are you telling people, switch to home treatment, go into the clinic to get your IVIG? I know you touched on this a little bit earlier, Dr. Brander. If you could, kind of what advice are you giving people about IVIG and their need for that?
Well, I think this just applying for patients already on it. I think the first question is now, otherwise, could they space it out? Was the infection history a year or two ago, but the winters are always a difficult time from everything, and can you minimize and space out the visit? I think switching from, again, as Tom said, switching, you can't get the IV set up for at home, so it'd be switching formulations, and whether the more appropriate thing is maybe to wait to do the infusion versus trying to switch formulations may not be an option with the given insurance, or might not have, the first time has to involve home health, and so, or home setup, I should say. So doing it for the first time might not be the best option for the patient. So I think if it is an option to not have to do it exactly every 4 weeks, that might be a good one. But if it was recently started for something that's really actively needed, then it might not be a good time to be trying to delay that out.
So
I agree.
I'm going to ask go ahead, Anthony.
A patient basis decision, but I have not canceled IVIG specifically because of this crisis.
I'm going to ask everybody, and I'm going to ask everybody to kind of give a brief summary or final thoughts here. We have a ton of questions left, but I think, I'm trying to be respectful of people's times, and we're very grateful to the panelists. Tom, do you want to start and see if there's...
Sure. So I have 2 points that I wanted to do as my wrap up. So with the area of shortages, I want to make sure that people understand that there can be some level of shortages at a local level, and that typically the pharmacy that you deal with only deals with one drug wholesaler. In this country, there's 3 major drug wholesale companies. And so your wholesale distributor may be out, but others have it. So there are options out there. Having worked in 2 major cancer centers, I know our specialty pharmacy could sometimes get stuff directly from the manufacturer and bypass those drug wholesalers. So contacting a comprehensive cancer center that has a specialty pharmacy might be an option to obtain it. And as we mentioned earlier, there may be alternative drugs. So we heard a little bit about acalabrutinib, that some people were concerned about that. If that person's never been on ibrutinib, it might be an option for them to be switched, obviously in conjunction with their physician. So, it does require that you coordinate with your insurance company and with your care team, but I don't see anybody having to go without drugs at this point. And then the other point that I wanted to bring up, we talked a little bit about vaccines, and I just wanted to remind people that with regard to the pneumococcal vaccine, there are currently 2 formulations of that. So the older formulation, which is Pneumovax 23, was on a cycle of every 5 years. And then a newer product came out called Prevnar 13, which is now the preferred product. So if you've never had the pneumonia vaccine, the recommendation is you start with the Prevnar 13, and then 12 months later, you receive the Pneumovax 23. If you receive the Pneumovax 23 only, and it's been over a year, then you could have the Prevnar 13 immediately. But if it's been less than a year, then they recommend that you wait the 12 months from the Prevnar before you get the Pneumovax 23.
And I'd add that the CDC has a whole section on this. If you go on vaccines for special populations, immunocompromised, if you
Correct.
don't remember the timing, it can get a little trickier in the vaccine order and stuff. If you have the choice is particular. There is one quick question I'll throw at you, Tom. People asked about, you talked about reducing the dose, obviously with physician approval to do that. Ibrutinib comes in capsules, but it also comes as pills. If you've got a 420 and you want to reduce it, can you cut that pill in half?
So that's not, you can't do that. So it's very specific not to break those dosage forms. The one thing, so it really is applicable to the capsule form where, with the 420, you were taking 3 capsules, a 280 is so 90 tablets that, were supposed to last you 30 days at a dose of 420 will now last you 45 days at a dose of 280 and may provide adequate relief, during that short period of time.
But just to advocate, I don't think patients should be making that decision to dose reduce themselves until we have clear evidence that there was a shortage. Certainly would not advocate for anyone to do that in practice or for patients to make that decision.
And I agree, Anthony, and I did mention that when I said it earlier, but I think it does warrant being repeated.
Dr. Brander, any final thoughts you want to share?
Well, just again to thank you for inviting me. I learned a lot of this. You have nicely consolidated the questions, but I know so many have come in and allow us to think about what's on patients' minds. And just in the post survey that you did, just in terms of, I think people staying closer to home, I think that's or at home, or so this physical social distancing is a great thing to be trying to do. But just remember, as long as you're keeping that distance, you can still go outside, do your normal, staying physically conditioned and as active as you can is really important. And there's great data of how keeping that up is protective, and one of the many things that you can do in a time that certainly probably an understatement to say we wish we could do more right now, but in focusing on the things that we can do, that's still a really important positive thing that you can do and don't have to stay in the house all the time.
So Dr. Brander, I'm going to push on this because there were some questions about this. If you can go for a walk and avoid being within 6 feet of people, if you can go for a walk, in your neighborhood or at the local park and there's not other people there, or even go for a jog or a bike ride and avoid people, that's completely fine for us to do, is it not?
There's been no evidence that it's not, and probably even as if you can keep that 6 feet or more, that's great. But remember, it is both distance and time. So if you can keep that distance, and remember, you're probably in that space of other people passing, like on the other side of the road, for a relatively short period of time. You're not standing there in a closed space, in a close room. And I think, again, this is, a risk and benefit statement, but if you can control the things like as much distance as possible, and you're there for kind of a brief time passing, the risk will never probably be zero, but I do get concerned about the risk of taking away people's physical activity and conditioning, because we know how important that is, and probably also a benefit in terms of the immune system. It's been shown with other cancers, and I think with blood cancers as well.
So I'm just going to follow up on that just to give a concrete example and tell me if I'm thinking correctly. We don't know everything about aerosol, but it does seem to suggest if you're like a physician in a room with a patient for a long period of time, or a dentist or somebody with a patient in, there may be aerosol in those circumstances, even if you're not doing a high risk procedure like putting them on a ventilator or something like that. But if you're in a locked room with that person, there may be aerosol. But if you're just kind of walking by somebody, in theory it could happen, but it's pretty unlikely. So here's my example. If I go for a walk, I'm okay. If I wait for somebody to get off a park bench who's been coughing, and I sit down on that bench, for 10 minutes, that may not be as smart as just kind of walking by the bench.
Yes, and again, this gets really complicated really fast because they're the asymptomatic people maybe before symptoms. That's different than a situation if you cough, of what droplet versus aerosolized, versus if someone sneezes at you, can create aerosols. The amount of virus in each of those at different situations, it gets complicated fast. But I think your scenario of trying to limit the distance and the time will help try to reduce those risks as much as possible. And again, versus the risk of staying at home all the time and not getting in any activity, I think we have to remember that that has its own risk too if people become deconditioned and locked in, let alone for kind of our mental energy and health.
Anthony, I'm not going to make you go after Dr. Leclair this time. I'll let you go next.
Yeah, I think she should have the last word for sure. What I was thinking about as I was sitting here today and last week, a couple of different things. Number one, again, our community is incredible for providing support. And so I highly urge everybody to come back, because I'm learning from these questions. And the fact that you're asking them indicates to me that these are questions that are very important to my own patients. And so I'm bringing this information back to the clinic. But I think more importantly, Brian, you've set a standard now for what the community expects after this crisis. And so I think that I'm hoping to see these type of forum where we get 500, 600, 700 people together to answer questions about CLL, because it would be nice to get back to that topic sometime in the future. And so I think that I'm really encouraged by the use of this technology to bring experts and patients together in a way that lets us communicate with hundreds of people that we would have never met before. And so I think for me, I'm looking forward to this format a lot more into the future.
Good. We're looking forward to it too. Dr. Leclair, I put you on the spot. You hit it out of the park last time, so you're under pressure now. Yeah.
Well, I'm going to try and do it word for word, although I don't think I've ever been able to repeat two things the exact same way. I have decided that everything is a risk-benefit ratio, to continue with some of the comments that people have said. Life has risks and benefits. So in order for me to deal with this, I have decided I will listen, read, look at, for science, things that come from the World Health Organization. If you live in the United States, from NIH, from CDC. I'm not going to listen to anybody else. If I live outside of the United States, again, the World Health Organization, and whatever your country's Ministry of Health is really trying to tell you. They will have the broadest overview of what is going on in your world. If I want to know about what's happening in my city or in my state, then I listen to my governor. And in Massachusetts, this is a plug, I happen to have a really good one who is doing an enormously good job at keeping everybody's both informed and less anxious. So listen to your governor, listen to your mayor. You want to know what's closed, when are they closed, what decisions have they made, how many people have this disease currently in your city. If I live in a city of 100,000 and there's only one case, I'm going to make decisions differently than if I live in a city of 100,000 and there are now 10,000 people who have this, because the risks have changed. So listen to your governors and your elected officials at that level. I want to listen to my physician. I tend to do that somewhat rarely, but overall, I want to listen to my physician, because they're the one, my healthcare team, my physicians, my physical therapists, my psychologists, my pharmacists, my whoever they are, probably know more about me than I do. They certainly know more about my genes, so that's possible. So I'll listen to them about what I personally need. I am not going to listen to my neighbor's ex-girlfriend who used to work in billing at the local hospital. I want to talk to people that I can trust. But last and perhaps most important to me, you are in control of your own life. You are the deciders. All these people are giving you, all of us today, are giving you advice. You're the one who decides, I am going to pick up that piece of fruit. I am not going to pick up that piece of fruit. I can tell you, by the way, that the virus is wimpy. It doesn't like heat. So anything over 75 degrees sounds like a really cool thing to do to foods that are not super perishable. I'm the one who decides that. I'm the one who decides that I'm going to stay up all night watching creepy movies and not get enough sleep. It is my choice how I live through this. And so make your decisions based on information that's real.
Thank you. We are so lucky to have these panelists aboard with us. I mean, it's so great. So, obviously we had, over 100 questions submitted today, and we had more than that submitted before this even began. So if we didn't get to your questions, we'll try to get to them over the next few days. The first virtual meeting is already up on the website. A second one, this one will go up very soon. I want to, again, so I want to thank you for being involved. Our motto is smart patients get smart care, and that's never been truer now. I want to thank our sponsors, thank AbbVie and AstraZeneca. And, when Anthony talked about the pharmaceutical companies being quicker and the sponsors of trials being a little looser, that's also what we found, is that normally it's a process to get support for patient education. It's months and months, and these happened in days and days. I mean, it was just entirely different, the responsiveness that we got to be able to put these on and do this. As you've heard from everyone, COVID-19 is an acute illness, and we are experts in a chronic illness. So as CLL patients, I think we can be leading the way to help other people deal with the illness, deal with the anxieties, deal with the decision-making. And this will pass at some point, and we will be left with dealing with our CLL. So let's not forget about that, and we're going to get past that. And in that regards, we have Dr. Neil Kay for Mayo Clinic, who will be and this is on April 28th at 10 a.m. Pacific time. He's going to be talking about the early stages of CLL and what you can do and why that's important. Everything kind of up to when you need treatment. He's going to be talking about that and the diagnosis in a similar format to we have here. We're going to be repeating this in 2 weeks from now at the same time, same place. We don't really have all the faculty worked out, but it'll probably be most of some familiar faces and some new people. There's always a change, because what the doctors aren't telling you is that doctors like Dr. Brander and Dr. Mato are being asked to sometimes shift to do other things because there's a physician shortage right now. So they're being asked to go back into the hospital and do more general internal medicine and less hematology specific stuff to care for patients because they're needed. So it's a little bit hard at the last minute. Sometimes people have to sign up. But we're going to have this. We're going to have on our COVID website, we have more and more information for you. Our quarterly newsletter just came out, and it has several articles and information on COVID. And as I said, on April 17th, so 2 weeks from today, we'll have another one of these. Please reach out. Please, you'll get a survey at the that'll be sent to you in the email. Please respond to that, because that helps us get feedback in terms of what we've done well and what we could do better. And again, thank you everyone for attending. I'll see you on April 17th and maybe on April 28th with Dr. Neil Kay. And with that, I'll just say thanks, and we're pretty much on time. Thanks, everyone.